I'm Cheryl-Anne Laird. I'm a partner here at Mazars, and I'd like to thank you for attending today on behalf of Mazars who are hosting, but also our partner in today's presentation, LIME Medicolegal. I might just start with the traditional acknowledgement of country. I begin today by acknowledging the traditional custodians of the land on which we meet today and pay respects to their elders, past and present. And I also extend that respect to Aboriginal and Torres Strait Islanders people here today. So just in terms of who's who and what we're going to do today, it's all in your hands, but Michelle's going to explain that to you. We have Michelle Safely, who is the General Manager of LIME Medicolegal, who is going to run events for us. And then we have Dr. Angus Forbes, who is an occupational and an environmental physician, and myself, who will be the panel members. So I hope you've brought some really interesting questions with you. No, we're not seeing everyone raging, but let's get started. I'm going to hand over to Michelle.
Thank you, Cheryl-Anne. So, Dr. Angus Forbes, Occupational and Environmental Physician, Director of LIME Medicolegal and Phoenix Occupational Medicine. So those of you who are here today probably know both of those names, and if you don't know both of those business names, please come and have a chat to us afterwards. Dr. Forbes has more than 10 years' experience in writing IMEs and significantly longer years of experience in occupational medicine, and that's both in the forces and in private world. He is going to be the key person to answer questions from you about work-relatedness, causation and management of health in your workforce. Cheryl-Anne is a registered psychologist. She's a HR and an IR practitioner, and she also has a degree in business because she doesn't have spare time, apparently. She has the unique ability to navigate the challenges of workers' compensation and psychological claims. So, before we start, please raise your hand if you have used the services of a HR professional such as Cheryl-Anne. And I'll add my hand to that list. So full disclosure, Cheryl-Anne is a support to the LIME and Phoenix crew. So we have used her services and are grateful for the experience that she has. Who can raise their hand and show that they either know of what an occupational and environmental physician is or who has used one before for their services? That's great, because you'd be surprised how many people say, occupational therapy, right? And there is a difference, a huge difference. But hopefully, for those of you who are unsure of what an occupational and environmental physician is and what they do, we can make that clearer to you today with some of your pressing questions. You'll notice there's some QR codes on the back of some of the chairs. Please feel free to scan that code. You can just pop your first name into the name section, or you can just put anon if you don't want to identify yourself, and we'll go through the questions. I dare say as we progress there'll be a lot of questions. We're unlikely to get to all of them, so we will certainly endeavour to answer those afterwards, either in an email or just socially. I did get Anna to do large print, but I have my glasses for the phone, so bear with me. Oh, thank you. So the first question, and we'll probably do a speed round at the end too, so if you can think of some questions, don't be afraid to sort of go for a yes/no sort of answer if you think that will help you. How do we respond to employees who say, my doctor thinks I should work at home for my mental health?
I might take that one because it's one we hear quite a bit. Where employees, and I do think this has been more so post-COVID, where we, particularly for employers who might have asked their employees to return to the workplace when they've perhaps had a long time working from home and kind of got used to it. The answer is that we need more than that. Okay, the answer is you would really need to understand what it was about the workplace which was preventing the person from working in the office, because it may well be that an inherent requirement of your job is actually to be able to attend the office. So people need to be a little clear about what it is they're looking for, but they also need to be quite careful about making those kinds of bold statements. And unfortunately, it's usually because they've attended their GP and said, I don't want to go back to the office, I would be stressed. So when you push for additional information, which you are quite entitled to do, the answer then becomes, well, it's not that they can't attend work, it's just that perhaps they would be better off or would prefer. So certainly do not take it as something that you need to just accept and move on if that is not necessarily something that's going to work for your workplace. Anything you want to say?
I'm not actually sure I have a lot to add medically, really. I mean, my answer would be to sound like a toddler, really, and just say, why? 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 Because that's obviously the important part. And I guess, obviously, as a doctor, I could do that and ask medical questions and kind of try and work out what that nexus is. And yes, I think maybe we're both slightly sceptical, but the general underlying reason is because I don't want to. And that's fine. It's like a perfectly reasonable opinion, but it's not necessarily a medical reason itself. But obviously, depending on the job and the person and the rest of it, there absolutely can be medical reasons. And I guess that's the trouble most companies have, is how much can you inquire in that space and how do you do it? And that probably is a very you question there, Cheryl. Obviously, from my perspective, once I'm asked that question, that's relatively simple if I can get the information, and usually I can. But how hard can they push is probably the big question.
There is no definitive answer to that question. You're going to hear that a lot today. But certainly you are allowed to ask for information which you require to properly manage your employees. So if we're taking this specific example, you would be able to ask for a proper medical opinion, or perhaps send them off for an IME to find out why, without sounding like the toddler, what is it about the workplace which is inconsistent with their mental health in terms of attending the workplace. And look, there will be times that people can't attend the workplace. I would suggest it's probably the exception and not the rule. And there may then be other considerations for you as an employer. For example, I know I've got some friends in the corner here who work for a school, a teacher who can't attend the workplace. Really doesn't matter what the medical evidence is, that's inconsistent with the inherent requirements of their job. Okay, there's really no reasonable adjustment that you could make that allowed them to stay home and allowed them to continue in their job. Now, that doesn't mean you don't try sort of things in the shorter term if there's an expectation that situation will change. But, for example, if they say this is it forever, I would suggest that's certainly one where you're entitled to ask those questions and you're entitled to act on the medical evidence when you get it.
So given that Angus handed the microphone to Cheryl-Anne, I think it's probably really important for him to explain, especially for people who've never used an occupational physician or any doctor to do an IME. Angus, why can't you tell them what questions to ask?
Because it's a bit leading is the main question. So we do frequently get asked, what questions can I ask? But that's a bit like me giving you the answer before you send me the patient, which is obviously, I'm not a lawyer, but I suspect a lawyer who got hold of that would have an absolute field day and smile themselves stupid, to be honest. So we can't do that. That doesn't mean we can't give you a little bit of advice about what to do. And I guess on that note, my advice in that area is like some things are pretty obvious. What is the diagnosis? Essentially, can they come back to work? Are there any accommodations to help them come back to work? And what is the duration of that? Is it going to get better? Is it not? That probably covers off on most things for most people most of the time, however you word that. I would also really strongly advise people that I have no problem with you having kind of default questions that you put in IME questions, but can you please not send me your default questions without reading them and see if they answer the question that you want answered? Because it's really annoying for me to sit there and go, my God, this is not what they want, and to fill it in, and then to have you guys go, God, this isn't the answer I wanted. He's an idiot. And then for you to come back and just delays things, and it's all a bit silly. Often it's kind of obvious what you want, and I can sometimes help you a little bit, but I can't just answer a question that you have not asked me. That's not appropriate for me to do that either. have a kind of default setting of questions is reasonable, but just make sure it does actually apply to the specific problem that you have in that one. And if there are, for example, inherent requirements of a role, and you're asking me if they can do the job, I need those inherent requirements of the role, because otherwise I'm going to do what the patient tells me the inherent requirements of their role are. Not that I believe the patient 100% all of the time, but because it's the only information I actually have to base that decision on. Right? And that may or may not work for you, obviously, but please don't blame me if that's what happens.
And I do think we laugh about templated questions, but I dare say Angus will recall the IME he had where he answered the first 12 questions to discover that question 13 was please do not answer questions 1 through 12. So it does happen. Crazy things happen in the IME world. We will have things where the wrong job role is put inside the referral and then another job role is referred to. So
not infrequent to have the wrong patient's name in there as well.
So yeah.
Can I just clarify that's never on a referral from us?
Never.
Never. Now, Angus, I always ask a general question before I start asking my specific questions, which is, could you please give me your medical opinion arising from, which I've always assumed was the way I allow you to tell me whatever it is you think I should know, although I will often also ask anything else you think I, as the employer or as the consultant to the employer, should know. Is that going to kind of help you if we're asking those more general questions as well?
Look, it does help me. I will try and kind of answer that question anyway, if you don't ask. It's just still a bit vague. That's the trouble. It gives me a bit of room to put some stuff in there. But again, if you have a specific question that needs answering, general question ain't going to cut it for you probably. So yes, it's useful. And yes, most of the time I'd probably just put not applicable or nothing else because I think I've kind of put all that stuff usually in the summary. But it's a useful thing. Some people are probably even more black and white than I am and will just literally answer the questions you do, and so it does give them a bit of room for leeway sometimes.
Great. Good to know.
So do either of you recommend your client getting in contact with you after whether you've received your HR report from the IME or whether after you've written the IME? How open are you to discussing the contents of the reports?
Look, I'm reasonably open to do it. I probably don't do it too much. I think office stuff sometimes is actually quite helpful. Like, Michelle's been doing this for ages with me as well, and I think sometimes actually it's the answers are quite obvious to us, even from an administrative point of view, that may not be obvious, particularly to people who don't arrange for a lot of IMEs. And sometimes reasonably simple questions, not too many though. We get the odd SUP which is reasonable, but I think most of those are when there's either further information or you just didn't ask the question you wanted in the first place, in fairness.
I'd say it's often the people that are doing their first ever and just wanting that bit of reassurance about how they're interpreting. But from your end, Cheryl-Anne?
Yeah, we tend to, if we get to read the IME, if we've got an outstanding question, we will often put a written supplementary question to the doctor, just trying to maintain that absolute independence. And in a lot of our cases, unfortunately, if perhaps it moves through to an employee no longer being able to do the job they want to do or no longer being able to do any job, there is always the prospect of litigation. And so maintaining that independence of the doctor by doing it all in writing is the way we tend to deal with those things.
We started this by talking about mental health as a component of needing an IME. With the new psychological code of practice that's been in play now for a couple of months, employers are still a little uncertain how to manage that. How do we know the difference between a medical issue and a HR issue?
Get comfortable, folks. This one's going to take a while. No, I don't know, because often there are very clear HR issues, there are very clear medical issues, there is a huge amount that falls into the grey. And you can't rely even on the employee themselves to necessarily know whether or not the response that they're demonstrating is usual or is it a symptom of perhaps an underlying psychological or psychiatric condition. And in those cases, in the grey, an IME is how you often decide those things. Because unless you're all registered psychologists, how many registered psychologists in the room? Okay, there's two of us who can probably have a stab at it, but the rest of you probably don't want to be making those kinds of judgments, particularly if there might be some adverse consequences for someone at the end of the day. That's when you refer to an IME to get an answer to the question about, is there an underlying medical condition? And often you do it as an exclusion. You know, if you're thinking that that might be the case, or the person is perhaps saying that is the case, even just having that excluded then allows you to treat it much more confidently as a HR or an industrial relations issue, without the concern or the fear that you might in fact be making someone's condition worse, or being unfair in terms of treating it as a HR issue when what you've actually got is a medical issue. Got a view, Angus?
I mean, obviously, with just the medical side, I mean, we've had, you know, workplace issues we've engaged Mazars for as well. I'm still, and we did talk about this briefly last time we spoke, that I'm still not really sure it actually really changes anything you do. I sometimes oversimplify things, but I'm still pretty sure that whole code of practice is basically don't be an arsehole. And I think that's probably pretty much the good starting point. Yeah, like, and it kind of is, isn't it? Like, you know, if people have an issue, manage the issue, talk to people, engage people. If you're not sure if it's an HR thing, ask an HR thing. If it's not sure it's a medical thing, ask them if it's a medical support. And I don't think people are going to fall, I think we agree. I don't think people are going to fall foul of that code of practice unless they were going to fall foul of the same stuff beforehand for just being psychopaths in the workplace, to be honest. It's to help people do it better, but I don't think the problems are significantly different. Sorry. Yeah, sorry, but repeat the question. So the question was essentially, the patient tells me stuff and then says, I don't want you to put that in the report.
And I just want to add to that, while you're having that part of the conversation, when after they leave the consultation, they ring up and say, I take away my consent. You no longer have that.
Well, they haven't done that.
Yeah. Yeah.
Yeah, look, I mean, yeah, it comes down to consent. You know, if as a doctor you want to get struck off, the surefire way to do that is to broach patient consent. You can be a totally incompetent surgeon and drive a Maserati, quite frankly. So, but break consent and you're probably in trouble. So, yeah, like, can't. That's the answer. They withdraw their consent. I can't send you the report, so on and so forth. Usually, I'm trying to think how many of those I've had. If they withdraw their consent for me to do anything with it, I can't send it anywhere. If I've already sent it somewhere and then they withdraw their consent, well, you know, that ship's sailed, mate. Let's, you know, get a time machine and find it. But I can't fix that problem. I can't send it again to someone else. Fair enough, but you know, yeah. I think your first question was in the report, and that does happen occasionally. Look, to be honest, for most of those ones, I just say to people, look, at the end of the day, because usually it's in a fitness for duty situation, I say, yeah, what I'm actually being asked to do here is to say that you are fit to go back to the workplace. Because actually the default setting is there's a defined problem here, otherwise you wouldn't be here, and your employer has concerns about your safety in the workplace. And if I can't say you're safe in the workplace, I'm not your employer and I'm not their lawyer, and I don't know how that's going to work out, but I'm reasonably certain you're not going to drive the train or the bus or handle firearms, right? Because I just think that's kind of a fairly logical outcome of this process. If your concerns are where does that report go and all the rest of it, you know, engage a lawyer, talk to people, that's fine. But my understanding is it goes back to this person who sent me the referral. This is going to be the information in it. And sometimes there's a bit of negotiation about what you put in, and sometimes you can work your way around that. And I don't think I've actually ever had it as a significant problem. I think when you explain to people that, yeah, the answer is, if I can't say they're fit for work, then actually there is only one other answer, which is you're unfit for work, and that's probably not the outcome they want. Then it usually kind of fixes it. People don't necessarily like it, but it is what it is.
There are potential HR or IR consequences of an employee being directed to attend an IME and then not participating effectively in the IME. So if the report comes back that says, I can't answer these questions because I've not been given consent to disclose the information, then you may well have grounds for looking at some kind of disciplinary action or issuing a direction. So when you're issuing your directions for people to attend IMEs, maybe we need to be telling them to attend and to appropriately participate so that the direction goes that little bit further. Can't say I've necessarily had problems with people, either those who are willing to follow the direction to attend an IME tend to participate. It's often the ones who refuse outright when you tell them that they're to attend an IME that are more problematic. And certainly a course of action in relation to that is where you are confident that you ought to obtain an IME, you issue a direction to do so. And if the employee refuses that direction, then that is a failure to follow a lawful and reasonable instruction, which will lead to disciplinary action. I have certainly been involved in many cases where employees have lost their employment on the basis of their failure to follow lawful and reasonable instructions, and including lawful and reasonable instructions to attend an IME. But you want to be sure you've got it right. And for those of you from the public service, you want to be sure you're following the Public Service Act to the letter. Not so hard in the private sector, but...
Is the Public Service Act around IMEs and direction IMEs, is that quite different to the private legislation?
There is no legislation that covers it in the private sector. It's case law, and the case law has developed over the years such that it is much more acceptable now to do so than perhaps it might have been 10 years ago. It just needs to be reasonable, and it needs to relate to inherent requirements of the job. And there needs to be some risk of not doing it, essentially, from, in short sort of summary. In the public service, there is quite a detailed process you need to follow, and you do need to follow it to the letter, or you'll find yourself not being able to proceed with that.
Obviously, fully accept the legal advice and all the rest of it, but it comes back a bit to consent from the doctor side. I've certainly we give patients a consent form. Some of them even read it. I ask if they have read it, and whether they say yes or no, I then tell them what I'm going to do and exactly what the form said anyway, so I know that I've done that for every single patient. Now, a number of those patients will then say, well, I've got no choice, I've just got to sign it anyway, or words to that effect. And I say to every single one of them, you absolutely have the choice whether you participate in this process. Okay? I'm not going to force you to say anything, do anything. I cannot touch you or examine you without your consent. So as far as I'm concerned, and I know Sid does the same, if they've signed that consent form, at least at that point in time, they agreed to that process happening. Because clearly, if they feel forced into giving consent, that is very arguably whether that's consent. I don't think it is. Obviously, I'm not a lawyer, but and I'm not going to proceed under that setting. I don't think it's stopped an appointment, but I've certainly spent an overly large portion of the appointment having that conversation.
And it may well be that from an admin perspective, we say that the appointment can't go ahead because the doctor has spent so much time trying to get consent or trying to explain consent, not coerce it, of course. There are those matters. There are the next appointment that has to go through. It can become really complicated. The 15 minutes earlier arrival at the appointment time won't necessarily solve all of that, but it does have to be a nurturing environment, and we can't force anything. We don't want to. Oh, sorry.
If you've got an employee with excessive sick leave usage,
Yes.
and you've had the support conversations to say, is there anything we need to be aware of the workplace negatively impacting on your health?
Did you read my next question?
Yes. And the sick leave continues to about, 50 to 60% of the roster time, consistently, and, they bring in medical certificates every time. But can you...
And do those medical certificates simply say medical condition?
Yeah,
Yep.
Something
Yep.
from a medical condition. So, would you then go ahead and request an IME? Is that the wise thing to do?
I'll hand you the thing, but essentially the question is excessive sick leave, a continued pattern of excessive sick leave, and how do you manage that?
Yeah, thank you. Absolutely. That would be one of the triggers for referring for an IME. Okay. You can do, there's sort of a step before that, you can do an absence management plan, which can then put some barriers around, particularly if you're expecting, you're thinking that it's probably, it's every Monday and every Friday, and you're seeing a bit of an ugly pattern. And my favourite is where you might have 30 medical certificates, but they're from 30 different practices. Doctor, how long you want this time? I've never met him, you know. But, yeah, you can do it around what a person has to do to access their sick leave in terms of reducing the med certs to single day absences, requiring them to, my favourite, and it tends to work, don't text me, don't email me, give me a call. And when they have to, you know, they're having that thought about, oh, I don't want to go in today, oh, gee, I have to ring the boss, I have to actually talk to them. Yeah, actually, I'm not that sick. I'll just go in. So it does make a difference. So there is that earlier absence management plan, but if that doesn't work, your IME is your next clear spot to go to.
Okay, and if the IME comes back and said that there's no conditions impacting on their ability to work, and the pattern continues, what's where do you go?
Okay, it's going to be a case-by-case basis, but I think the answer you're looking for is excess absenteeism ever a reason to separate from employment? And the answer is yes.
And I saw on the Fair Work site that there was a percentage of time that they quoted.
Yeah, you can't dismiss someone because of an absence for work within 3 months. Now, what that means is it just opens up another avenue. They can make an unlawful termination application in those circumstances. Keeping in mind, though, it's not particularly relevant, for example, if you know someone's going to be absent for 6 months, you know, and that on that basis you might say it's inconsistent with the employment agreement. You wouldn't have to necessarily wait. But certainly the Act does provide protections to people who might just be unfortunate, break a leg, you know, have a car accident, and so that we're not out there as employers going, aha, got him, he's not in for 2 weeks. No, you do need to look at the absence and decide it on a case-by-case basis.
I would also say, medically, I don't know, legally, like if it's obviously going to be a bit long, does that mean you have to wait until 3 months before you instigate any action, like arranging for an IME, which may take several weeks to get an appointment, several weeks to get the thing back?
Absolutely not.
I was hoping that was the answer.
We would always try and engage with the workers treating GP if they have a consistent treating GP first to try and get information to assist with the absentee management. Is that something that you would recommend? Because sometimes I find that the direction to an IME is a much more sort of severe, formal sort of process, which may automatically then put a barrier up as well. So in order to try and address that engagement, that person-centred approach to not put them offside.
Yes. So in case people didn't hear the question, is it better to go to their treating general practitioner before you go down the path of an IME? The answer is sometimes. First of all, you need to get consent to do so, and often
even
people
with
are
consent,
reluctant.
the GP still might not talk to you.
Yes.
That's the other
I was
issue.
going to say. And you need to remember that the GP is their practitioner. So they will often refuse to answer questions which might lead to a detriment to their employee. So if you ask them, can this employee undertake this particular inherent requirement of the job, and if they suspect if they say no, the employee is going to lose their employment, that's going to have possibly a pretty bad influence, I'll be interested in Angus's view, on the therapeutic relationship between that individual and their treating practitioner, because essentially may well be seen as being complicit with the employer, in which case, in those cases, the independence of an IME allows you to get the medical information without that therapeutic relationship, without the ongoing desire to be able to continue to assist that particular person.
I think sometimes you also need to help people have an honourable way out, so to speak. And again, it comes down to the questions you ask people. So if you say to the GP, is there any risk of them coming back to work performing the full inherent requirements of their job, or should we consider getting an IME with a specialist occupational physician to discuss that risk? Then you might get a much different answer to whether they're fit to come to work. And it kind of gives them an opportunity to do that. And I have seen 1 or 2 of those, and they actually seem to be quite well dealt with.
Yeah, I can't say I've had a huge amount of success with engaging with GPs. It is usually more an outright no or very careful responses, for which I'm not critical of the GP, because they do need to maintain that therapeutic relationship to continue to assist their patient, and they don't want to destroy that.
And I think often when you get those vague, being careful with words, things, that actually tells you a lot.
I'll do a plug for Phoenix Occupational Medicine. There are more options than GP or occupational physician for an IME. So there are companies like Phoenix Occupational Medicine, and there are a lot of OCMed providers who you can talk to before you need an IME. It's much lower cost, it's a quicker turnaround response. It's not the depth of the IME, but typically you should be reserving the IME for when things are really going sideways. Hopefully not when you've waited that long, but if you're wanting to get a little bit more clarity. There's not just those two options, and I think we tend to, you know, we were talking before, a problem happened once, happened a second time, and the next time I'm handing 18 pages of notes to Cheryl-Anne's team to help me work through. There was no, you didn't realise you went from 2 dot points to 18 pages. Don't let that happen with your medical conditions. You know, Angus works in Phoenix with cases of what is happening with this person.
We've actually pushed that quite hard, so our work cover will fund those appointments as well. And our kind of sell, for want of better phrases, it's that kind of 6-week point. You know, if people have, like classically, it's musculoskeletal strains and sprains, kind of regardless of what you've done, most people should be better within 6 weeks if that is genuinely the diagnosis. And if you're not, then waiting for 6 months, 8 months, a year to kind of send off an IME when you'll be managing for a sprain is probably medically a little weird. And by the time we've got that stage, a whole bunch of things have happened that are probably irreversible, whether that's they've fallen out with the employer or the employee, whichever way around that has worked. So trying to get in early can help. I'm sorry, you tried to ask a question ages ago. I'm so sorry.
Here was first, and then we'll come to you. Sorry, I'm taking
Thank you.
your
Yeah, I
job.
Thank you.
I don't tell IME about my customer friends.
I suppose leading on from the question before, so what I'm starting to see quite a fair bit is there's quite, like you said, there's quite a grey area and crossover between the HR IR space and compensation and injury. Where there's a clear delineation, I like to try and keep the separation between church and state, as a matter of speaking. But I suppose as an example, you've got a person with physical injury and has conduct and behavioural issues in the workplace. You try and manage the behavioural and conduct, but then suddenly there's certificates coming in either for the physical injury or the perform a scripted certificate saying suffering from a medical condition when they're asked to come in and discuss whatever. How do we work around that? Because particularly where there's already a compensable injury, it's quite challenging to try and manage those sorts of cases, and I think we will start seeing more and more of that.
Do you know where to start?
No, I don't either. So I was hoping
do you know
to
where to start?
partner
Anyone? Look, it is really difficult.
Yeah.
But what you do need to remember is, and particularly even the occupational, the psychosocial code of practice, makes it very clear it's not only about the individual, it is about the workplace. So what you can't do is turn a blind eye to inappropriate conduct and behaviour in the workplace merely because the person also has an injury, and that includes a psychological injury. You know, if someone's behaviour is inconsistent with your code of conduct, albeit that it may well have some influence from a psychological or psychiatric condition, you don't tolerate it, okay? Because that is not fair. That's a psychosocial stressor for perhaps the rest of the workplace. So I do think that where you can, keeping that division between church and state's a really good idea, but sometimes you can't, and you do need to still act, even though they may well be producing med certs around a separate illness or injury. And unfortunately, and I don't mean to say mean things about some GPs, but some GPs will write people a medical certificate because they ask for one. And so there may in fact not necessarily be a genuine underlying serious medical condition But they really just don't want to come today because I know I'm going to have that performance discussion. I know I'm going to have to answer for the fact that I snotted someone on the nose yesterday. You can't allow that to sort of be your reason for not pursuing those matters, and often there are other options in terms of doing things in writing, which are not inconsistent with their medical certificates. I rarely see, unless you ask people to, if that's their condition, medical certificates that say they might not be able to attend work, but they're able to still resolve whatever the underlying issue is. So they're able to still participate in a process, albeit they may not be able to actually front up at the office.
And on that note, by the way, if they are capable of participating, I had one recently who was capable of participating in performance management for a 2-month period, which his employer completely went past, and then by the time he was not capable of participating, they decided they wanted to do it. Unsurprisingly, that hasn't worked out really well for anybody. So do take your opportunities and your windows to do the right thing.
Just in terms of the advice to perhaps not engage with the person's treating medical practitioner with consent and going to the IME, would your advice change if that were in the state public sector?
Wholly and absolutely dependent upon the engagement you have with the general practitioner. If you have engagement which is assisting you to know what you need to know from a medical perspective to manage the person and to move forward, then absolutely engage with them. If that is not the case, so if they're either not willing to participate or they're not giving you the answers that you need, keeping in mind it's not a criticism of them. There are a whole range of good reasons, sound reasons why some doctors won't do that, particularly around psychological and psychiatric illness and injury. If you thought your GP was telling your boss that, you had some kind of condition that you say you didn't have, you wouldn't be very happy with them and you'd be looking for a new GP. Okay, so there's that therapeutic relationship. I don't believe the Public Service Act makes a difference in relation to that in terms of if they're engaging effectively, absolutely. Yeah, I don't think the guideline prevents you from doing that where you can demonstrate that you're not getting the appropriate responses that you need to enable you to properly manage.
You still need that engagement first.
I'd certainly go there first. In my experience, a lot of the time it doesn't take long because the first time you ask, they won't give you consent, or the doctor says, "I got the consent, but I'm not saying anything."
I just had a thought. It's always a worry, isn't it? That we kind of talked about doctor sick note, how much time off and all that kind of stuff. Actually, the other big trigger, which people sometimes just kind of don't treat the same way for reasons that are probably slightly obvious, but it's strange when you look at it with hindsight, are exactly the opposite. Someone who's totally unfit and then all of a sudden is totally fit when it suits them. Like, that is no more believable than the first one was, and I think that's still illegal. Treat, like, if you have concerns about it, just because the doctor says they're fine does not mean that you don't have concerns. Do they actually understand the issue, the inherent requirements of the role, the risk involved, and all that stuff?
So talking about risk, sorry, go on.
Sorry, I just wanted to ask a question of when we're doing a direction for an IME.
Yep.
For those medical certificates that just say medical conditions, we don't know which specialist is
Yep.
relevant in that. Is that, would the first support or be an occupational position?
Yes.
I just wanted to check on that, even if you suspect it's a mental health issue.
Yeah, look, we do lots of psych stuff. Like, if you're a GP, a third of your workload is psych. And probably more than that, seeing as most pain disorders actually really can't be separated out from psychiatric disorders anyway. So, we're generalist physicians, essentially, and absolutely do that. There is, of course, a risk that we might just say, this is a psych thing, and we need a psych specialist as well. And that's fine, but I don't see any other way you can solve that, unless you want to send everyone to the psychiatrist first, just in case. And
Or having a robust telehealth process with doctors like Angus, who can help you, again, in that Phoenix space, but sort of give you some answers a little bit more quickly before you slide down that path. We were
Sorry, and I was just going to say the psychiatrists are often great being psychiatrists. They're not often great at that return to work kind of piece as well sometimes. So sometimes you do need an occupational physician just to kind of help you with that piece as well, with that specialist advice.
Sarah, did you have a question?
Yeah, I was just going to ask if we're referring through Phoenix before we get to an IME, what exactly we telehealth
So-
consultation, and is that with the employee or is that with the employer first? Like what
So the companies that we do telehealth with, typically it will be a supervisor, and often it's an incident that's just occurred at that time.
Okay.
Or it could be that someone's come into your office and said, I really don't feel well, and you might say, let's call our OCMED provider and have a chat about that. And depending on what arrangement you have with the provider of that service, will depend on what information you get back. It's a long list.
I mean, we want to do that as a treating doctor role, as opposed to an IME role.
Yeah.
And I think that's what you're alluding to. And look, and that's just for that reason that to be honest, Sid and I just got really annoyed of having to do IMEs and saying, well, the reason this is all cactus is because the diagnosis is wrong, the investigations is wrong, the management was wrong, and the work restrictions is wrong. Other than that, it was great. And after a year, it's not working. And it's great we sit there, we're cocky and arrogant a year later with all the paperwork and the full full access to the retrospectoscope to look at all that stuff. But sometimes it was pretty obvious at the beginning as well. And I just think we then have that position with a bit more time, a bit more expertise to look a bit more objectively at what it is without that existing doctor-patient relationship, while still being actually their doctor. So it's definitely not an IME, but it's a treating thing. But there is.
The counter to that is there's less power or less there to compel them to attend if it's not an IME. If you're seeing them in a treating doctor instance. So for example, with a non-work related conditions, like just getting medical condition, perhaps a telehealth appointment isn't most appropriate in the first instance because there's nothing that compels them to attend to speak to you. We can't sort of say you have to attend.
The question for those who can't hear, sorry, it's just about that power, the power to compel. Sounds like something. And look, you're right. You can't. I don't know. I would hope at that stage we're not quite into that realm of compelling people. And that's one of the things with IMEs is that we do get into that quite adversarial state of mind. But that's because it's quite a long way down the track, and most people, most of the time, want to get better. And I think the idea there is to actually kind of get in early enough to stop it becoming that whole adversarial issue, which is a self-sourcing pudding of failure, usually, unfortunately.
It helps keep the communication open, which I'm sure every person in this room can attest to it going yuck when there's been really broken down communication, and it can really help to be in there earlier and supporting both the business and the employee. We touched on risk a couple of times. So one of the comments made by you, Cheryl-Anne, was about it's not just about the risk to that person, but to the people around them. And I think that is something that can quite often be lost in the discussion. It becomes very much just about that individual. Can you talk to examples of when the risk has to be considered for other employees or the general public, perhaps?
Yes, and most people automatically kind of go to psychological and psychiatric injury here, and it probably is overrepresented in this space, where behaviours which arise or are contributed to because of an underlying condition, be it diagnosed or not, might result in the person's behaviour being inappropriate. Okay, you have to take into consideration in those cases the risks to others. However, it is not restricted to those cases. So to use a fairly recent example, we had an employee with eyesight issues, and that employee, as part of their job, needed to use live electricity. So the risk was not just to him, but to others. Okay, so, and that person needed to navigate in a warehouse situation where people were driving forklifts but had very limited sight. So again, the risk is, certainly the greatest risk is to him, but you also have to think about, well, what are the risks to others who might witness near misses or might witness behaviour which is going to arise directly because of the person's medical condition and their inability to undertake certain tasks. So it really becomes a very individual basis around what are the implications in the workplace of whatever the person's medical condition might be. And of course the obvious one is don't go to work if you've got COVID. You'll give it to everybody. So there are some issues around some communicable, transmissible diseases or conditions. Now,
No, I don't want to do war stories as such, but we also did one recently where a worker was having significant anaphylactic reactions at work. She was relatively happy with that because she kept surviving. Her colleagues were less happy about actually having to give her mouth-to-mouth and adrenaline injections on a fairly regular basis. That's a significant risk. I do not get that many questions in those IMEs that they're often about the risk. They're not that many are very actually say risk to others. Not an insignificant portion, but probably more should do. Yeah, for a lot of things. Yeah.
Sorry.
In terms of risk or liability with a person's private medical condition that is progressive, and perhaps the workplace and that individual both value that person, but where does that liability or risk sit where you consider that there's a chance that the role that they play in your business could accelerate or contribute to the denervation of conditions?
Did everyone actually hear that because it was from the back? I don't need to repeat it. Yeah, it was very impressive. It was good. Risk is a lawyer question, isn't it?
Yeah. Risk and liability go hand in hand. I don't think that they're always necessarily, when you say one, you mean the other, because some risks don't necessarily lead to liability. But certainly there's a connection. And as an employer, you need to be aware of those connections. I would hope that in the circumstance you describe where someone has a degenerative perhaps condition or a progressive condition where you know they're perhaps going to get worse over time, they would be ones where I would be suggesting you should be able to build a good relationship with their treating practitioner, because unlike where you're perhaps trying to say you're not kind of fitting, you're not doing your job, in this case you're kind of saying, and the earlier you get in to say, we want to be able to support this person in the workplace as long as possible, but we need your help. But there may well come a time where the risks, and therefore in this case the liability, become too much. You may have run out of the things that you can reasonably do to assist in accommodating that person. Now, it may be that you can make some changes to their role over time, that you may be able to reduce their hours over time. And I think if you've got a really good relationship and it's a tripartite arrangement between you, them and their doctor, you will probably have much more success in keeping them in the workplace longer. If you've got someone who's not willing to tell you and not willing to let you access, you will get to that risk phase so much quicker. And it's okay to have that sort of robust discussion with them that says, this is going to inevitably end up somewhere. We want to make that as long into the future as possible, and to do that, we need to be working with your practitioners. We need to be understanding that we're not putting you at additional risk. And through that process, you'll also need to make sure you're not putting other people at additional risk. So, for example, if they're a bus driver, probably a bad example given the recent tragedy, if they're a taxi driver, and whatever their degenerative condition is makes them their capacity to safely drive greater than the average person, you will have to make an assessment to say, is that a risk you're willing to take? There's some licensing laws there that are probably going to help you, but in all of those instances, it's about understanding what can I reasonably do to not make things worse for them, but also not make things worse for others.
We're really close to time.
The lady up in that corner
Yep.
has been
Thank you.
I just thought I'd add to that when we were talking about the impact on others, and therefore the risks of that not just being psychological, but being physical injury, where someone can't do a confined space entry or they can't walk for long distances, and so the risk of the psychosocial impact on the team where they go, well, my workload is then higher, and that can create that bigger impact on the whole business. So there's that organisational focus as well.
Yep. I had an example of that where I had an organisation as a client who came up with this fabulous idea that they had some jobs which were lower physical engagement, and they would use those for rehab jobs. And so they basically had a room full of people. It was in food production. It was a high sort of musculoskeletal injury. But they found that they ran out of space in the rehab room because people who used to transition through the more difficult, the less difficult, the easy jobs were only at one end anymore, and you were breaking them. So, we had to say, not great idea, great to see you really wanted to help, not the way to do it. Because you're putting an unfair burden on other people.
We'll extend by just a moment for some really quick responses. The IME's done, and a copy went to the GP. GP disagrees. No, you're completely fit, or no, you can't do any of that. Who do you listen to, IME provider or GP?
IME provider. The reality is, if you look at the case law, the hierarchy starts with specialists, goes down to GPs. It's not in every case, but as a general rule, always go with a specialist over a practitioner, particularly if they're a treating practitioner.
And the last one, how do you choose which specialist to use for an IME?
How do I choose? Well, I'll tell you how I choose. I look and see whether I can tell what the injury or illness is, and if I can't, I speak to someone like Michelle and say, here's my client's issue, here's what I've got, who do you recommend? Because we all need to understand our limitations, but Angus probably has a better idea about who you use.
Look, I certainly have my own idea. It comes down to, again, the questions, right? What is the question that you want the answer to? And if the question is, has something caused something, then the person you should ask would be someone who's trained in what causes something. In Australia, the only physician who's trained to do that is actually an occupational environmental physician. If you want to ask, should I use a 6-inch screw or the 4-inch screw to do a tibial osteotomy, ask an orthopaedic surgeon. If you want to ask, is their bone broken, you could ask the orthopod as well, or a GP or anybody else, probably my kids. So it does depend a bit what you want. Right? Certainly, if it comes down to fitness for duty, which is mostly what we talked about, it comes down to risk of going back to work, which ties directly in with what actually causes injuries, then that's an occupational physician most of the time, right? In fact, and I can't really think of a time that it isn't, unless it's obviously a psych thing, which is psych, and we've kind of covered that already. There's plenty of room for doing psych RMEs. Availability is hard. Reports take a long time to come back, and you still sometimes have that work rehab thing. There's often physical stuff in there as well, and it gets a bit complicated, so we end up in those ones as well. I was actually quickly, so it just occurred to me, talking about risk, liability. Doctor's version of risk is always a bit weird. So workers' compensation, is employment a significant contributing factor to their injury? I ask a lawyer what the definition of significant is, and the answer is not insignificant. That is literally the answer, right? So it does vary, and it's really quite difficult. So risk is strange, and I think one of the biggest pushbacks we get, again, come back to questions actually, is can this person do their job? Yes. Does this person need any restrictions? Oh, yeah. They need it. Well, hang on, Dr. Forbes, how can you say they can do their job and they need those restrictions? Because that means they can't do their job because they've got to do those things. They say, well, they can do it right now. I can walk across the road outside here without looking left, and I'll get across 8 times out of 10. 2 times out of 10, I'm going to have a significant and very foreseeable injury, right? What I should do is be restricted to using my eyeballs or the crossing, okay? It's possible to be both, be fit for doing a job, but actually have a very foreseeable and significant risk of injury. So ask the right questions and understand what the answers come back, and that's probably risk for doctors.
Thank you. Thank you all for your patience as we extended. I think I've learnt a lot, and I hear a lot around the water cooler at the office, and certainly Cheryl-Anne has given me a lot of advice over time. I do hope everyone's taken something away that they can put straight into practice in their workplace, or can help them understand the process a little bit more. We'll all be milling around for drinks, so please don't hesitate to come up and ask any of us. My team are just sitting to the side. If you've got any other questions related to Lyme or Phoenix, and Cheryl-Anne's team...
Up, because they're spread out everywhere like I teach them.
So HR questions to Cheryl-Anne, but thank you all, and thank you to Cheryl-Anne and Angus.
Thank you very much.
Thank you, Michelle.
Thank you.